Hi, my name is Lindsay Tellis. I'm a nurse practitioner student at Auburn University, and I'm going to be talking about my stakeholder presentation and how to improve medication adherence in patients with type 2 diabetes. So first, starting off, just a little introduction. Type 2 diabetes is one of the world's most progressive diseases, and there's more than 440 million people worldwide with this condition. Managements can be long-term. This is dealing with exercise, diet, continuous medical care, and it can cause quite a few complications if you don't manage it correctly. A lack of family support and knowledge can lead to poor adherence, and up to 37% of patients with diabetes stop using glucose monitoring medications within the first year. So it's really important to educate our patients, especially if they're newly diagnosed with the disease. So moving on, so my PICO question that I have formed is among adult patients with type 2 diabetes, which teaching methods or strategies compared to others improve patient adherence to medication regimens. So my population consisted of adult patients that are 18 years and older who have type 2 diabetes, and the different teaching methods or strategies used to educate patients on diabetes. So we're focusing on which teaching methods work best for those patients and how we can implement this in our setting, everyday clinic situations. Comparing it to other teaching methods or other just usual care. So basically every physician or practice would educate patients, but we're still seeing an increase in diabetes. So that would be considered the usual care. So we're trying to figure out which teaching methods, in addition to the usual care, will improve medication adherence. The outcomes are to determine which of these teaching strategies improve medication adherence. So a literature review and summary of the evidence. So I use CINAHL, PubMed, and Medline databases with the range of 2015-2019, using the search terms adults, type 2 diabetes, education, self-management, medication adherence, and teaching strategies. Also a really good resource that I was able to use throughout my setting assessment was the Alabama Diabetes Association website that had a lot of good links for patients to learn, a lot of good statistics on diabetes. The summary of evidence, so my articles that we acquired were 2 level 1 systematic reviews, 3 level 2 randomized control trials, 1 level 3 quasi-experiment, and 1 level 4 cross-sectional analysis. Throughout this literature that was synthesized and found, the teaching strategies that we're focusing on is a messaging and monitoring strategies. This would be using text messages, voice recordings, online situations where you're dealing with the patients, educational sessions. So this would be about a 30-minute session or pharmacotherapeutic sessions that are harping on how to use certain medications. And all of this was evaluated by the MOS adherence scale or a MDKTU scale, which was only used in 1 of the reviews. And another teaching or education strategy is using family involvement, involving families with the teaching sessions and any sort of education with the patients. So my recommendations that I've made throughout my project was that educational sessions should be provided in persons that improve knowledge of medication skills for medication administration, and ways to manage type 2 diabetes. So each educational session will last around 15 to 20 minutes and provide at every follow-up visit until medication adherence is achieved. My second recommendation is dealing with follow-up. So at each follow-up visit, we would encourage the patient to bring support systems or family members with them to each visit, and we would be teaching the family and the patients on medication adherence. This one you can't really force people to bring their families, so we would just enforcing repetition of encouraging this to each patient at each visit. My third recommendation was also a grade A recommendation, stating follow up with a provider every 3 months to help maintain self-management behaviors, get labs drawn, and encourage medication adherence until medication adherence is met or compliance is met. We would continue to see these patients every 3 months until we could tell that this patient was being compliant. So my setting assessment. So the setting was at a diagnostic and medical clinic in Daphne. This was an internal medicine doctor. And the results, so this physician saw about 25 patients a week with type 2 diabetes, averaging around 1,300 a year. Based off the ADA, we have a hemoglobin A1C of less than 7% would be ideal goal. Based on this physician's reports, you can see in the grid that the hemoglobin A1C in this physician's patients, there was a 12% of them that were still greater than 7%. And the rest of the physicians at the DMC clinic had around 23% greater. And then there was a 65% of patients that had a hemoglobin A1C less than 7. So overall, this clinic had a very good patient database that was compliant with their medications. But there's still that 12% that has a practice improvement that needs to be made. So my focus was figuring out where these patients are lacking in adherence and how can we improve this. So in the setting assessment, the provider's input on need for practice improvement. So a gap in care that this provider saw was that some physicians at this location reported the recommendation that the ADA states that you need the first primary line of medication would be metformin, and then the second generation medications, sulfonylureas or GLP-1s, in addition to metformin. So these can be pretty expensive, and so the gap in care that the provider mentioned is that since they're so expensive, that these patients are resistant to taking them. That would be hard for us to implement. So another gap in care that was noted is she did notice that they need more teaching methods to improve medication adherence, including family members, and discuss medications on how often to monitor blood glucose. A lot of patients might not bring their families, even if they're on that borderline of being compliant or not. The few patients that were asked, so there was one day where we saw, I had a total of 3 patients that day that had diabetes. 2 of the 3 patients that were interviewed had their family members. The other patient did not. They all agreed that the need for practice improvement is to influence on healthy habits and lifetime changes. They also agreed that if they had some sort of monitoring system or an app, that they would be they would actually agree that they would use the app to help remind them take medications, and that they were receptive to any sort of additional teaching or teaching sessions on just having to keep them reminded of how often they need to take their blood sugars, when to take the medications, so on and so forth. So they were very receptive in this implementation plan. So this implementation plan that I set up for my clinic, so the project leader and the physician would gather around 10 to 15 participants over a 10-day period, diagnosed with diabetes and had a hemoglobin A1C greater than 7. Participants will be evaluated in the clinic at 1 month, 3, 6, 9, and 12 months. A pre and post implementation questionnaire will be given to each patient to determine a baseline of compliance with type 2 diabetes and medication adherence. During the visit, there would be a MOS score that would be calculated, A1C that would be drawn, and a 15 to 20-minute educational session. Support family would always be encouraged each visit, and hoping that they would bring their families. So each session, so what we're doing at each session, we're going to be covering overall diabetes information, risk of complications, medication adherence, the use of a MyTherapy app, and a blood glucose log education. So what's given to these patients during the sessions? There's pamphlets and booklets that the ADA provides. There's a blood glucose log that we would give them to keep them up to their blood glucose levels or monitoring them. And also a website given to each patient, associated links for education support. And after each patient's seen at the visits, the patient will receive a phone call from the project leader 2 weeks later to evaluate progress and answer any questions that the patients might have. Any sort of barriers that might be related to this would be if patients didn't have a smartphone and they could use or that they couldn't use the app, if they didn't have internet access for the website URL, or if they couldn't get to the clinics, so they couldn't get an actual drive to certain areas. So what we would do is we would provide these pamphlets on paper, and we would give them to participants and find some sort of way that we would call them and update them to keep them compliant. So the evaluation plan, so we're evaluating, there's a pre and post patient questionnaire that would be distributed, a self-reported MOS questionnaire that would be given at every follow-up visit. A hemoglobin A1C would be drawn, and that would determine the diabetes compliance throughout the project. And a blood glucose log will be evaluated at each visit. So if a patient has their blood sugars running 200 and 300 and they think that's okay, we are able to see when are they taking these blood sugars and what their levels are to determine the changes that need to be maybe made in their medications if they're not working for the patient. All data would be collected by the project leader and inputted into an Excel spreadsheet and then transferred to the SPSS for analysis to figure out if this actual evaluation or this implementation project worked in this setting. So in conclusion, if patients recognize consequences of non-adherence and be willing to explore changes to increase their overall quality of life, patients tend to be informed inappropriately about their condition and have to take responsibility of their own management, leading to poor compliance. So if they're informed inappropriately, then their compliance might not be the greatest. So our jobs as healthcare providers is making sure they're getting the right education, the right resources so that they can improve their diabetes, improve their medication and compliance. And overall, we're wanting to increase the quality of life for these patients, decrease any sort of complications in the future. And, you know, these sort of patients really just are dear to my heart, and I really want to see a change across a wide range, and just starting in a local area in your own clinic or your own backyard is what our job is able to do. So here are my references that I used throughout my project, and that's all. So thank you for tuning in. And I appreciated this semester dealing with this project. Thank you.